Welcome to today's video, where we tackle the medical puzzle known as disseminated intravascular coagulation. Picture a condition so intricate that it can cause both clotting and bleeding, often in the same patient, and is triggered by everything from infections to cancers. Intrigued? You should be. Stay with us as we explore the complexities of this, its relationship with the immune system, and the latest research that could change how we treat it. Let's get started. Disseminated intravascular coagulation is a severe thrombohemorrhagic condition. According to ISTH, it's an acquired syndrome involving systemic activation of coagulation, causing microvascular damage and organ dysfunction. The etiology are: it can be triggered by various disorders including severe infections, malignancy, trauma, obstetrical complications, vascular malformations, severe immunological reactions, and heat stroke. Clinical features, signs and symptoms include bleeding, bruising, low blood pressure, shortness of breath, and confusion. Manifestations: 1. Microvascular thrombosis causing organ dysfunction, gangrenes, acute kidney injury, and sometimes pulmonary and cerebral thrombosis. 2. Bleeding manifestations like petechia, ecchymosis, and necrotizing purpura, bleeding from vascular access sites, and mucosal bleeding into various organs. 3. Shock due to blood loss, impaired endothelial permeability, or decreased vascular tone. Epidemiology: incidence varies based on geographic location, clinical setting, underlying condition, and diagnostic criteria. Mortality rates range from 31% to 86% despite supportive therapy. Presence of DIC is the strongest predictor of death within 28 days in sepsis patients. Diagnosis is context-dependent, considering the clinical presentation. No single lab test can diagnose DIC. Combinations of clinical biomarkers are used. Diagnostic algorithms. 3 main algorithms exist, 2 in Japan and 1 by the ISTH. ISTH diagnostic score for overt DIC is based on platelet count, PT, fibrinogen level, and D-dimer, along with clinical factors. A score of 5 or more indicates overt DIC. Pathogenesis of disseminated intravascular coagulation. Overlapping pathways exist. Complex and multifactorial, involving uncontrolled activation of coagulation, platelets, fibrinolysis, complement, innate immunity, and inflammation. Characterized by widespread endotheliopathy within a dysfunctional microcirculation. The initiation of disseminated intravascular coagulation. Interaction between pathogens, dead cells, and molecular patterns activates pattern recognition receptors. Activation of PRRs induces tissue factor expression and microparticle release from monocytes. Pro-inflammatory cytokines are synthesized, amplifying TF expression. Initiation of coagulation occurs via the extrinsic pathway due to TF expression. Factor XII autoactivation can occur upon contact with pathogens, PAMPs, DAMPs, and cell debris. Long-chain polyphosphates from bacteria and short-chain polyphosphates from platelets, as well as extracellular nucleic acids, DNA, RNA, induce FXII autoactivation. This triggers the intrinsic coagulation pathway. Both extrinsic and intrinsic pathways converge into a common coagulation mechanism. Thrombin generation occurs, leading to platelet activation. Formation of fibrin and thrombus is the end result. Pathogens, PAMPs, NETs, cell debris, and DAMPs activate the complement cascade. 3 pathways for activation: classic, CP, lectin, LP, and alternative, AP. All pathways converge at the formation of C3 convertase. In CP and LP, C4 is cleaved into C4b, convertase component, and C4a, anaphylatoxin. C4a increases endothelial permeability via PAR1 and -4 signaling. C3 convertases from all pathways cleave C3 into C3a and C3b. C3a activates platelets and leukocytes. C3b acts as a potent opsonin, aiding in opsonophagocytosis of various particles. C3b is also a component of C5 convertase. C5 convertase cleaves C5 into C5a and C5b. C5a is a chemoattractant and activator of leukocytes, and induces TF on monocytes and Pi1 on endothelial cells. C5b initiates the formation of C5b9 terminal complement complex, membrane attack complex. C5b9 creates cytolytic pores in cell membranes, causing bacteriolysis or cell death. C5b9 also activates platelets and induces monocyte TF expression and microparticle release. Additional components involved: MASP, mannose-associated serine protease, MBL, mannose-binding lectin. Interaction of pathogens with neutrophils, macrophages, and platelets leads to the formation of neutrophil extracellular traps, or nets. Components of nets, such as histones and DNA, nucleosomes, amplify the coagulation pathway. Result is increased thrombin generation. Nets and pro-inflammatory cytokines induce tissue factor expression on monocytes. TF expression leads to TF-mediated coagulation. Cell-free DNA supports contact activation and triggers the intrinsic coagulation pathway. Extracellular histones activate platelets and induce exocytosis of endothelial storage granules. Granules include Weibel-Palade bodies and release von Willebrand factor and P-selectin. Released factors promote microvascular thrombosis. Thrombin also acts as a secretagogue, similar to the effect of extracellular histones. PSGL1, or P-selectin glycoprotein ligand 1, is involved, likely in the adhesion and signaling processes related to thrombosis. Interaction of pathogens with neutrophils, macrophages, and platelets leads to the formation of neutrophil extracellular traps, or nets. Components of nets, such as histones and DNA, nucleosomes, amplify the coagulation pathway. Result is increased thrombin generation. Nets and pro-inflammatory cytokines induce tissue factor expression on monocytes. TF expression leads to TF-mediated coagulation. Cell-free DNA supports contact activation and triggers the intrinsic coagulation pathway. Extracellular histones activate platelets and induce exocytosis of endothelial storage granules. Granules include Weibel-Palade bodies and release von Willebrand factor and P-selectin. Released factors promote microvascular thrombosis. Thrombin also acts as a secretagogue, similar to the effect of extracellular histones. PSGL1, or P-selectin glycoprotein ligand 1, is involved, likely in the adhesion and signaling processes related to thrombosis. Disseminated intravascular coagulation with a thrombotic phenotype is triggered by exposure to pathogens, PAMPs, cell debris, DAMPs, and nets. Leads to systemic inflammation and endothelial injury. Results in activation of coagulation and suppression of anticoagulant and fibrinolytic activities. Causes uncontrolled thrombin generation and microvascular thrombosis. Consumption of fibrinogen and other clotting factors often leads to bleeding. Both microvascular thrombosis and bleeding are damaging to tissues and organs, often leading to death. Disseminated intravascular coagulation with a fibrinolytic phenotype is more common in trauma and acute promyelocytic leukemia, characterized by excessive fibrinolysis due to massive release of tissue plasminogen activator and plasmin generation. Early hemostatic clots are destroyed, releasing fibrin fragment D dimer. In APL, cell surface annexin 2 binds TPA, protecting it from inhibitors and enhancing plasmin generation and fibrin degradation. Proteases like neutrophil elastase and cathepsins are released by leukocytes during inflammation and trauma. These proteases degrade fibrinogen and fibrin, forming fibrinogen degradation products. Increases the risk of bleeding and contributes to organ failure and death. Thrombin-activatable fibrinolysis inhibitor is also a component to consider, although its specific role in this context is not mentioned. Therapeutic approaches in disseminated intravascular coagulation. Traditional methods are: address underlying medical conditions, supportive therapies such as platelet and plasma transfusions, and heparin administration. Targeted therapies are: tissue factor neutralization, administration of recombinant tissue factor pathway inhibitor, supplementation of antithrombin and activated protein C. Experimental approaches are: antibody neutralization of factor Shia and factor Sha, inhibition of the contact pathway, use of complement system inhibitors, targeting neutrophil extracellular traps, fibrinolytic agents, inhibition of plasminogen activator inhibitor -1, Supplementation of tissue plasminogen activator. Future directions are utilization of genomic data, application of machine learning algorithms. If you like our videos and want latest updates, research insights, and expert discussions on critical care medicine, subscribe to our YouTube channel today. Algorithm for managing disseminated intravascular coagulation. Step 1. Initial assessment. Confirm clinical suspicion of DIC based on symptoms and risk factors. Perform immediate laboratory tests including complete blood count, prothrombin time, activated partial thromboplastin time, fibrinogen level, and D-dimer. Step 2. Identify underlying cause. Investigate for sepsis, trauma, malignancy, or other potential triggers. Initiate treatment for the underlying condition. Step 3. Hemodynamic stabilization. Administer fluids and vasopressors as needed. Monitor vital signs continuously. Step 4. Supportive therapies. Transfuse platelets or fresh frozen plasma based on lab results. Administer heparin if indicated. Step 5. Targeted therapies. Consider tissue factor neutralization or recombinant tissue factor pathway inhibitor. Evaluate the need for antithrombin or activated protein C supplementation. Step 6. Experimental approaches. If standard therapies fail, consider antibody neutralization of factor Shia or factor Sha. Explore the use of complement system inhibitors. Evaluate the role of fibrinolytic agents. Step 7. Monitoring and reassessment. Repeat laboratory tests at regular intervals. Adjust treatment based on lab results and clinical response. Step 8. Follow-up. Monitor for complications such as organ failure. Evaluate the effectiveness of the treatment regimen.